Hello, I'm Rachel Siewert. I'm an Australian Green Senator from Western Australia. I've been in the Parliament about 15 and a half years and I'm on my last term. During that time, I've learnt so much and I've met the most amazing people who are doing brilliant work around this country. I've been involved with a range of inquiries, committees, including the expert panel for the constitutional recognition of First Nations peoples, things like national redress, the inquiry into forced adoptions. I'm chair of the Community Affairs Committee, which for me has been the best part of being involved in Parliament, because it's where you actually deal with really important issues to people, social issues and health issues, and you feel like actually you can help make a difference, and you meet the most amazing people and learn of people's lived experience. My job here today is to introduce the 2021 Libby Harricks Memorial Ovation, and it is with great pleasure that I do so. For 22 years, Deafness Forum of Australia has been running this series, and we've heard from academics, from researchers, from policymakers and advocates. All of them have been raising awareness around the importance of hearing health. This is a topic that is very close to my heart. My mother has a hearing impairment, so I know firsthand the debilitating effect that it can have on a person's well-being and life if hearing health goes unaddressed. It is a message that we heard throughout the Senate inquiry that I chaired into hearing health. The Hear Us report, which looked at hearing health in Australia, mapped out a large number of recommendations to address if we are going to ensure that Australia is addressing hearing health. During that inquiry, we heard not only from researchers the excellent work that's being done, but we also heard of the lived experience of people. It is absolutely critical in Australia that we continue to address hearing health. We also learnt in the inquiry of the impact on our First Nations peoples, and particularly children, of the impact of hearing health and what happens if somebody's hearing health goes unaddressed. It's particularly pleasing to see that the government has released the roadmap to hearing health and wellbeing. It's really, really important that that is implemented. It is with great pleasure that I introduce the Libby Harricks Memorial Ovation speaker. He's well known around the world and in this country, Professor Harvey. He is an absolute legend. He has spent a distinguished career working on addressing hearing health issues, and in particular, otitis media and its impact in First Nations communities. Anywhere you go or speak to in this area of hearing health, they all know Professor Harvey, and in particular his outstanding work on the hearing health of First Nations peoples. He has produced hundreds of published works. He has worked for the World Health Organization and has made an outstanding contribution to addressing hearing health in Aboriginal communities. Although he himself will say there's still a long way to go, he has contributed in an outstanding manner to addressing otitis media, not only addressing the impacts of it, but also putting the issue on Australia's agenda. It's a great pleasure to introduce Professor Harvey, and we'll all learn so much from the ovation he is about to give.
Thank you for your kind words, Senator Rachel Siewert. You are a champion for the field of hearing and ear health, as are Steve Williamson from Deafness Forum, Professor Kath McMahon from Macquarie University, Professors Calvin Kong and Amanda Leach, AM, from the Centre of Research Excellence in Aboriginal and Torres Strait Islander Ear Health, Chris Perry, AOM, from Deadly Ears, Minister Ken Wyatt, AM, Barry McKinnon, AM, and my colleagues Paul Higginbotham and Lara Scher from the Earbus Foundation. My gratitude to my teachers and mentors, too many to name, my colleagues, both medical and paramedical, to the audiologists, teachers of the deaf, nurses and Aboriginal health workers, I owe a debt of gratitude for their dedication and teamwork. To the institutions and groups such as Aboriginal Medical Services, hospitals, research institutions such as Telethon Kids Institute with leaders like Professor Fiona Stanley, AC, Jonathan Karapetis, AM, and Deborah Lehman, AO, and researchers like Dr. Ruth Thornton, my eternal thanks. And most importantly of all, the children I've been privileged to treat, from those of the Sioux Nation in Minnesota, Maori, Balinese, Pacific Islander, and Aboriginal and Torres Strait Islander children. Thank you for allowing me to try and make a difference to your lives. I acknowledge the Whadjuk Noongar people, the elders past, present, and emerging, and the land upon which we meet. Thank you to the Deafness Forum and Audiology Australia for the honour you have shown me in your invitation to give the 2021 Libby Harricks Memorial Oration. Libby Harricks was exceptional. In spite of progressive hearing loss, she accomplished so much in her advocacy for deaf and hearing impaired people. It brings to mind Nelson Mandela's dictum, "What counts in life is not the mere fact that you have lived. It is what difference we have made to the lives of others that will determine the significance of the life we lead." In this oration, I will discuss the worldwide problem of Indigenous ear disease. It's truly an epidemic, but a silent one. Why? Why does it occur? What are its effects? How can we treat it? And the biggest question, how to close the glaring gap in ear and hearing health between peoples of the same Commonwealth. My distinguished friend and colleague, Professor Andrew Smith, who gave this address 2 years ago, emphasised from his years leading the World Health Organization ear strategies the critical role that public health initiatives have in detecting, preventing and treating those causes of deafness and hearing loss. In the World Health Organization UNICEF Lancet Commission on a Future for the World's Children, chaired by former New Zealand Prime Minister Helen Clark and published last year, the multiple threats of climate change, ecologic degradation, migrating population, conflict, pervasive inequalities, and predatory commercial practices to health and the future of all children were outlined. They noted childhood is the ideal time to intervene. Intervening, though it's a time of vulnerability, it's also a time of opportunity. If we intervene in childhood, there are lifelong intergenerational benefits. Consider that brain elasticity and neurogenesis are at their peak, at the critical time for cognitive and psychosocial skill development. And so, finally, it's in the last decade, recognition of hearing loss has been acknowledged, with hearing loss increasing from the 11th cause of years living with disability in 2010 to the 4th leading cause in 2015, ahead of headline-grabbing conditions like diabetes and dementia. Apart from the Lancet articles, the World Health Assembly ratified in 2017 a resolution and action plan for prevention of deafness and hearing loss. In Australia, Minister Ken Wyatt unveiled a 7-year roadmap for ear and hearing health. Yet 500 million people have disabling hearing loss, 7% of the world's population, while 1.34 billion have mild to moderate hearing loss. 32 million children have this all too often overlooked silent handicap, especially those in low and middle income countries, and Indigenous nations in particular carry much of the burden, especially in Asia, Sub-Saharan Africa and the South Pacific, and uniquely in first world countries such as the USA, Canada and Australia. It is the Indigenous child with hearing loss that we address today. Indigenous peoples, First Nations, Aboriginal peoples, Native peoples. They are descendants of the earliest known inhabitants of an area. We contrast them with groups that have settled, occupied or colonized the areas more recently. Indigenous societies inhabit every climate and continent except Antarctica and number 350 million people. My research focuses on chronic suppurative otitis media in Aboriginal and Torres Strait Islander people. And in this talk, I will embrace them all as Aboriginal people. Worldwide, there are grim statistics. In Australian Aboriginal, New Zealand Maori, Native Americans, Inuits in North America and in Greenland, excessive prevalence of hearing loss and ear disease are only too well documented. And these are sometimes geographically within first world countries. In India, Tanzania, Guam and the Solomon Islands, there are prevalence rates for chronic suppurative otitis media, CSOM, unfortunately an acronym that we'll be hearing a lot of over 4%. The World Health Organization figures show that 60% of the world's burden of hearing loss is preventable. Much of it is permanent sensory neural hearing loss from noise exposure, ototoxic drugs and chemicals, infections fully preventable by cheap vaccines, poor nutrition and trauma. Of particular concern to me and you is the last great preventable cause of conductive hearing loss, middle ear infections or otitis media and the long-term complications. It's not surprising that the risks and causes for otitis media are similar in Indigenous people worldwide. Chronic suppurative otitis media is a disease of poverty. Poverty brings overcrowding, poor nutrition and hygiene, lack of running water, lack of access to medical care, exposure to smoke from cigarettes, wood and dung fires. Blameless young children in such poverty have up to 90% prevalence of otitis media. And even in poverty, otitis media strikes Indigenous children earlier, harder and more often. Remember, the WHO deemed chronic suppurative otitis media prevalence over 4% a serious public health problem requiring urgent attention. In Aboriginal, Inuit and Native American children, not 4, but 33% of children suffer from CSOM. It kills 21,000 children every year worldwide. Acute otitis media is an abscess deep in the confines of the middle ear. After painful pus pressure build-up, it may discharge, rupturing the eardrum and discharging into the ear canal. If there's discharge for more than 6 weeks, then we call it chronic suppurative otitis media, where there's a perforation. However, the infection may settle without the rough relief of a perforated eardrum. Glue ear, a nasty glue indeed, infected and coating the bones essential for converting sound waves to neural waves. Following this, we may see development of cholesteatoma in over 10% of children with long-standing hearing loss. And these can invade the middle ear, mastoid, and into the brain. So otitis media can be complicated by mastoiditis, facial nerve paralysis, meningitis, and even brain abscess. These are spectacular, obvious, and rapidly recognized with a good chance for treatment. But it's the silent development of hearing loss without such obvious markers that is more likely to be missed. These are the children under 3 who have speech delay and language development issues. The processing areas in their brains are starved of the auditory input they're crying out for. As they grow, they can't learn new hearing-related tasks. They can't learn at school. If you can't hear, you can't learn. That's our mantra, time and time again, on our remote visits. But it's the Aboriginal child with long-standing glue ear and chronic suppurative otitis media who suffers the most from their middle ear disease. To quote Bob Dylan, "Now is the time for your tears." In their first 5 years of life, the average Aboriginal child has 32 months of hearing loss and glue ear, whereas a non-Indigenous child has 3 months. In remote Aboriginal babies, almost all, by the time they are 12 weeks of age, have glue ear. Almost all, by 12 months, have had at least one attack of otitis media. The predictable associated hearing loss affects a third of Aboriginal children for the entire duration of their childhood. Is it surprising that they're inattentive at school, socially isolated, unenthusiastic about school attendance, early abandoners of formal training and school, untrained for any vocation, seeking solace in drugs and alcohol, and all too familiar with the justice system? In Darwin Jail, 93% of Aboriginal adult prisoners are Aboriginal, and they have long-standing hearing loss. So why? What's causing this epidemic of otitis media and its complications in Indigenous populations? Overlying it all is poverty, early bacterial colonization of the nose and throat from exposure to infected siblings in overcrowded homes, premature cessation of breastfeeding, poor nutrition, a lack of clean running water, so difficulty maintaining hygiene, passive smoking in overcrowded homes, lack of access to medical care. And unfortunately, otitis media doesn't obligingly strike only on the day before the health worker visits. So more immediate factors for development of otitis media can be put into 2 major categories: the host-related and environmental factors. A major cause of the disproportionate, frequent and early development of middle ear disease in Indigenous babies and infants is the failure of their immune systems. They just don't respond as strongly as non-Indigenous babies. And to the overwhelming nose and throat colonization by encapsulated bacteria to which their environment exposes them. It's these bacteria with respiratory viruses present in the nose, throat and middle ear that result in recurrent acute otitis media, chronic suppurative otitis media and glue ear at an early age, often before the age of 6 months. In addition, genetic factors may play a role. On the bright side, well, breastfeeding can ameliorate the effects and protect against the development of otitis media. And the environment. Good housing is critical. Urbanization worldwide has led to slums where 40% of the world's children live in overcrowded, unsafe, unhealthy, and socially excluding dwellings. Overcrowding in substandard homes with inadequate number of bedrooms, with the average number of Indigenous households of 5, twice as many as in non-Indigenous households. In some remote regions, up to 19 Indigenous people live in one home. Overcrowding places children at risk of recurrent upper respiratory infections. Then these become complicated by middle ear and lower respiratory tract infections. And smoke, it gets in your ears. In the Kalgoorlie otitis media study, passive exposure to cigarette or other environmental smoke significantly increases the risk of recurrent acute otitis media and otitis media with effusion. Also, lack of access to running water and lack of early access to medical care. So, the impact of otitis media in children's development. By virtue of its longevity, it affects their language and speech development with secondary effects on school learning, socialization, general development, and later vocational outcomes, and as we mentioned, interaction with the judiciary. The areas of cognitive development most likely to be affected by hearing loss associated with otitis media and its sequelae are auditory processing skills, attention, behavior, and language, together with speech, of course. The specific auditory processing skills affecting these children include difficulty with sound localization and difficulty discriminating speech in noisy backgrounds. If English is a second language, then there is once again a reduced ability in these children to understand in background noise. Corey Williams has noticed these myriad of factors that impact on the ability of an Indigenous child with otitis media to achieve speech and language. These are on the associated table being displayed. They include early onset of otitis media under 12 months of age, more than one episode before 12 months of age, long periods of infections, poor or no access to medical management, pre-existing cognitive or language deficit, disrupted attachment, and degree of hearing loss. If this hearing loss is compounded by a noisy classroom and the child also has a secondary central auditory processing disorder, then the child will be significantly disadvantaged educationally. Prevention of hearing loss. And this is what Benjamin Franklin said about that. The World Health Organization categorizes prevention in 3 tiers. Primary prevention to avert an adverse health condition, secondary prevention to detect a condition early and to treat it promptly, and tertiary prevention to reduce the impact of an established condition and restore function where possible. So, significant preventable causes of hearing loss include otitis media, maternal rubella, other infectious diseases, perinatal problems, ototoxic medications, consanguinity, and loud noise exposure. The prevention of otitis media in Indigenous children, apart from vaccination and appropriate and early medical intervention, is related principally to addressing the social determinants of health. Vaccination has led to a modest drop in acute otitis media episodes in Indigenous children, but it's the fundamentals of public health that are the essential factors requiring attention to effectively prevent otitis media. We should have attention to noise protection, such as from rifle fire and snowmobiles in Indigenous children in Canada, as well as education and legislation to reduce noise damage from personal musical devices. When I was in Bali after the bomb blew up in 2001, many of the young adults there suffered severe hearing loss and ruptured eardrums. Strategies that address the social determinants of health include treatment of overcrowding. In New Zealand, just by addressing this, the reduction in chronic suppurative otitis media in the 1980s in Maoris reduced by 50%. Clean water, the swimming pool study. Improved nutrition and breastfeeding. Reducing passive smoking. Keeping flies away from food. Face and hand washing, the BBC program. Ensuring all vaccinations are up to date. Regular health checks. Early intervention for infections. And education programs regarding the prevention, early diagnosis and treatment of ear infections. These preventive measures are where those at the coalface in Indigenous communities, the primary healthcare workers, nurses and general practitioners are the most important to address this condition, in association with Aboriginal, Indian or Inuit health services, together with government and non-government organisations. Secondary to these, audiologists, speech pathologists, teachers of the deaf, as well as otolaryngologists support and treat those affected children. Globally, it's well known that persistent, consistent, culturally appropriate interventions develop and deliver the best outcomes in terms of disease and hearing outcomes. Ear and hearing care in Indigenous populations at the global level. Stakeholders in the hearing health community at all levels should join forces to ensure member states have access to educational materials such as the World Health Organization ear training manuals. Equipment and low-cost hearing aids, cochlear implants and telehealth services should be made available. At the country level, we should take attention to the call for action by the World Health Assembly. We need to integrate our strategies for ear and hearing care within the framework of our health systems. There's a need for collection of high-quality data, human resource development, early identification and management services, noise control, and improving access to hearing technologies and communications. The services to Indigenous patients should be culturally appropriate and safe. At the regional and community level, early and appropriate antibiotic treatment for acute otitis media and topical drops and local treatment for chronic suppurative otitis media with timely referral to surgeons for grommets and middle ear surgery accompanied by audiologic rehabilitation is essential. As hearing health professionals are scarce in low and middle income countries, capacity building and education are a high priority. As hearing health improves, we hope that research and innovation may allow, as in India, trained technicians performing laryngoplasty procedures or the new tissue-engineered techniques with reduced operating time, where in this case, this child's operation took 10 minutes rather than an hour. In Australia, the 2020 otitis media guidelines and the new otitis media app improve access to the most up-to-date evidence on best practice in otitis media and hearing loss prevention and management for Aboriginal children. Thank you, Amanda. Different models of hearing and ear care. And here we quote Chairman Mao. The policy of letting 100 flowers bloom and 100 schools of thought contend is designed to promote the flourishing in the arts and the progress of science. So community-based ear clinics, whether by fly-in and fly-out ear health teams, such as in the Queensland Deadly Ears program, or mobile units with sound-treated buses like the Earbus Foundation of Western Australia, or Variety Club earbuses in New Zealand, or our Bali earbus, where we saw 5,000 children in the Bali region. These are essentials to provide diagnostic and therapeutic ear health in the local community, especially in rural and remote communities. This is often closely allied to local community health organisations such as Aboriginal Medical Services, providing on-the-ground support and their own ear health teams as well. Aboriginal health workers, community, school and child health nurses are the linchpin, providing ongoing care between ear health team visits. Community liaison and education workers are important members of the team, as are health promotion officers. Initiatives such as the MRFF project chaired by Professor Catherine McMahon are exploring innovative methods to co-produce, implement and evaluate a community-based model of ear and hearing care for Aboriginal children, with strengthened partnerships between health in the early years through to primary education. Eventually, the aim is to have for each community dedicated Aboriginal ear health workers and Aboriginal community liaison nurses, ear nurse specialists, audiologists and general practitioners, providing secondary support, and ENT surgeons and other groups such as Hearing Australia providing tertiary services. The exponential growth in telehealth, especially during the COVID era, has significantly enhanced the capabilities of remote consultations, either as live or store and send consultations. Complex audiologic procedures such as brainstem evoked response audiometry or mapping of cochlear implants can be supervised by telemedicine, as can surgical procedures. The standout telehealth centres and ear health are in Alaska and Canada, with validation of significant benefits both clinically, with wait times, and financially with cost. Here in Australia, teleotology and teleaudiology programs have been going for over 10 years, but there is a significant need for more such initiatives. Surgical buses. Globally, fully equipped surgical buses have been used to perform surgery in urban, rural and remote locations. Between 50 to 70% of day surgery of surgical procedures are possible by day surgery, and they're ideally suited, particularly otologics surgery, for these buses. Examples include those in Solomon Islands, India and Bali, as well as New Zealand. It's very popular with patients because they have access to surgery nearer to their home rather than going hundreds or thousands of kilometres away to have their surgery. Hopefully the next generation of ENT surgeons will continue to advocate for surgical buses, ideal in Australia's vast outback. This is the interior of the bus, which opens up. Indigenous ear hospitals. In Anchorage, Alaska, the Alaska Native Medical Center has an 173-bed specialized hospital offering comprehensive medical services to American Indian people living in Alaska and Alaskan natives. The 9 full-time staff ENT surgeons provide medical and surgical management as well as telemedicine communications to remote communities throughout Alaska, with significant cost savings. The community health aides in each village liaise with the patients to ensure this is effective. Now, there are other adjunctive services which are helpful, such as Hearing Australia, a government-sponsored agency which provides innovative programs such as Plum and Happy, hearing aid fitting and classroom amplification systems. Other important members are speech pathologists, teachers of the deaf and other paramedicals. And let's not forget the interface of medicine and education. Teachers are often overlooked and Aboriginal education workers are often overlooked. And they're critical in the school-aged child's ear and hearing health. So how do we close the gap and address this silent epidemic? We start with community-based organisations educating parents and carers and treating the children at the earliest stage of infection with frequent opportunistic hearing screening by health workers and nurses, utilising telemedicine for the more difficult cases and expedited treatment, including surgery. We should advocate, develop and ensure pathways into addressing professional inequality on vocational training for Indigenous people. In order to close the gap in ear and hearing health equity, we need to consider the 7 steps suggested by respected public health advocate Professor Ian Ring recently. They're all relatable to First Nations globally. We must set achievable and fully budgeted targets. Needs-based funding, and it should be 3 times greater, the need, because of the burden of disease, than for non-ATSI populations. There should be a focus on services, from resourcing and policy issues at the national level through to staffing, training and resourcing at the regional level. Training, we must develop a national training plan to ensure all involved in the field are trained in culturally appropriate service delivery, with capacity building for Indigenous staff, a linchpin. And management, we have to have a formal, integrated, multi-layered management system underpinned with information and evaluation systems. Continuous quality improvement, the need for proper systems to measure, monitor, and evaluate the quality of services. Output assessment is good, outcomes assessment is essential. Learning from national and international experience, adaptation of successful programs using systematic application of current knowledge to the local regional services. In conclusion, 60% of Indigenous hearing loss and ear disease is preventable. The major problem of chronic middle ear disease is preventable in the majority of cases by diligent application of early diagnosis, timely management, appropriate supportive habilitation with accompanying translational research and attention to the underlying social determinants of health. Hearing loss cannot and must not continue to be a silent epidemic. Thank you.